So hi everybody, my name's Steph. I'm one of the doctors at Wythenshawe Hospital, IMT2 doctors. I've been sending you all the emails, and I'm new to the team this year. So this will be the first year of me kind of navigating everything. For those of us who were with us last year. And so this is just my presentation on ECG topic, the basic things. It's just so that we understand the basics of ECGs with the kind of has a bit of background information. So I think Ahmed's going to keep an eye out on any questions if you want to pop them in the chat, and he'll interrupt me as appropriate, but if not, we'll answer them at the end if that's okay. And we'll also put the feedback form in at the end as well. So obviously feel free to do that. There is some bits that will be more interactive that I might ask questions to everyone. So yeah, if you feel free to put those answers in the chat. Yeah, so we'll get started if that's okay. Also, I am on holiday, that's why this is my setting. So if my connection goes at any point, then that's why. So as I said, the aims is just to have a kind of a systematic approach to interpret ECGs and to look at common things that you might see on an ECG. And this is one of the things that I've found on Google. But essentially, life at med school is like an ECG, ups and downs and roundabouts. So I'm just want to start. So this ECG I'm going to refer back to a few times, just so that we can apply what we learn elsewhere. So I'm just going to give everybody a minute, really, up to 2 minutes, to just have a look at this ECG, write down on a piece of paper or note in your phone anything that you've noticed from this ECG, and then we'll come back to it and we'll discuss it as we go along. So this is from a real patient in the last kind of 12 months, so just makes it a bit more kind of relatable if it's someone that an actual patient. So I'll just set a timer on my phone for let's see what you think. Sorry about that. I think I just cut out there, but the timer, I think the timer's up anyway. So let me just get you back. I've just moved to see if it's any better in here. There we are. So apologies for this. So I've given you a minute, so we'll talk about it as we go along. I'm not going to talk about it now. So first, I'm just going to go through how we approach an ECG. And if you've done any kind of revision on this, you might have seen this multiple times, this kind of checklist. But essentially, we want to think firstly about the clinical scenario. So ECGs are part of your entire assessment of a patient. They shouldn't really be looked at in isolation. They might be a patient with chest pain, palpitations, syncope. They're looked at as part of your assessment for the patient. But you also want to know you've got the right patient, you've got the time, the right date, because some patients can have, 10 ECGs in their folder, and you want to know you're looking at the one that, is relevant and at the time you want to see it from. And then firstly, regardless of the checklist, you can have a quick glance and you look if there's anything obvious. Because the more ECGs you look at, the better you will be getting at like pattern recognition to just spot things without really having to always go through the entire checklist. So that is something that you will develop over time, and just a quick kind of reminder that you don't always need to take the time to go through all of something if something obvious kind of pops up. So then the rest of the checklist is kind of as you would find elsewhere. So 1, you want to know what the rate is. 2, what's the rhythm? So is it regular, irregular? And 3, what's the axis? So we'll talk about that shortly. Then you go through basically each part of the QRS complex. So are there any P waves? If there are, what do the P waves look like? What's the PR interval? What's the QRS what does the QRS look like? Is there any Q waves? Next, what's the QT interval? What's the ST segment look like? Is there ST depression, ST elevation? And finally, what do the T waves look like? So we'll go through each of these things one at a time and how you look for them within the ECG. So firstly is calculating the rate. So I don't know if anybody wants to just pop in the chat how you calculate the rate, if anyone knows. Yeah, that's one way to, so there's 3 kind of main methods. So there is 6 times the number of QRS. So the number of QRS, this is in a standard rhythm strip. So be really careful because you can get catched out if they, for some reason, don't have the normal 25, millimeters per second rhythm strip. It's not gonna work in that case. Like that has happened to one of my colleagues before. So, it does happen. So make sure it's the right speed before you do that. So you can either do, well done, Stephen. So 300 divided by the number of big squares between the RR interval. Or you can do 1,500 divided by the number of small squares before the R interval, or the one that you can do very easily and quickly, which is the number of QRSs on the rhythm strip and times by 6. That's with the definitely got the right size paper and everything. So this I've just taken, just as a quick glance, just so when glancing at things that, if there's 1 big square, then that's approximately the rate's 300. If there's 2, then it's 150, 3, 100, 4, 75. I mean, you'd work this out. But as I said, over time, the more ECGs you look at, the quicker you will be able at calculating this. And then you're basically assessing, is the rate bradycardic or is it tachycardic? So if it's less than 60 beats, then it is bradycardia, and if it's over 100, then it would be tachycardia. Okay, and then next you're going to do is assess the rhythm. So I've just got 2 examples here, rhythm strips, and then how we would then assess the rhythm. I quite often end up doing this by putting a blank piece kind of over the and lines on the kind of RR axis. I do at least 3 and then move it along to see if the gap's the same. It's hard to do this on a PowerPoint, so done the best I can, really. So these are 2 different rhythm strips. So you can see the first one, that both the gap is the same. And this is what if I was drawing it, I'd draw these little lines on a piece of paper. And then you can see this one, that it's slightly different. So essentially, is it regular or is it irregular? So far, we should be able to know, 1 is my ECG, what the rate is the person bradycardic, tachycardic, and 2 is the rhythm, regular or irregular. So the next thing we're going to talk about is axis. So axis, people often get a bit stressed about axis, get a bit confused, but And all these little diagram things can be a bit confusing, but essentially I'm just going to give you a very easy way of figuring it out. So in this rhythm strip on the side, the axis is normal. And you know this because in lead 1 and lead 2, both of them are positive deflections, essentially. So in this rhythm strip, this will be a left axis deviation, and I'll explain why. So in lead 1, the QRS complex is positive, and in lead 2, 3, and AVS, it's negative. So the quick way to look at this is that between 1 and 2, they're leaving each other, so they're going away from each other. So if we go back to the other one, you would have seen that they were both positive, but in this one, they're going away from each other. So therefore, this is a left axis deviation. Then this one would be a right axis deviation, because in lead 1, the QRS complex is negative, and in lead 2, it's positive. So they're going towards each other, essentially. So the way to remember this is the right axis, and they're reaching for each other. I got taught that they're right for each other. It's like a little love story. They're leaving each other if it's left axis deviation, and then right axis, they're going towards each other. But whatever way you remember it, that's essentially the difference. So I'm not going to go into the causes of right and left axis deviation. We can save that for another talk. We're just trying to think about, when we're looking at an ECG, what's kind of happening here. So if we go back to my initial ECG, we can now apply those first 3 things. So one is, anyone tell me what one was again? Was the rate. So can anyone, yeah, so yeah, about 70, so 75-ish. So I think, so yeah, as I said before, obviously check the speed. The speed's the normal speed. Here I have done the kind of line to line, just, but roughly it's about 3 to 4 big squares. So yeah, 70 to 100-ish. And then the next thing was the rhythm. So do we think that this is regular or irregular based on my little lines? Yeah, regular. So this is not, this person has got, it's a sinus rhythm because it's not bradycardic and it's not tachycardic, and it's regular. So it's a sinus rhythm, essentially. The next one is the axis deviation. I've already put the arrows on, so what do we think that this is? Are they leaving or are they right for each other? Yeah. Yeah, they're leaving each other. They've said bye. So this is a sinus rhythm with a left axis deviation. So we've done the first 3 things, and then we'll go into the rest now. The next one is, we're going through the QRS complex now, and the first one is, are there any P waves? In rhythm strip. And this is important because P waves are representative of your atria contracting. So you want to know if you've got a synchronous atrial contraction. So this is mainly important for rhythms like atrial fibrillation. So in atrial fibrillation, there's no P waves because there's no synchronous atrial contraction. That makes sense. And then is the P wave before every QRS. So is the relationship between the atria contracting, is it relating to when the ventricles contract? Because that's what your QRS complex is. And this is important kind of for heart blocks, because, is there been a delay? And is that the reason why there's no synchronal contraction between your P wave and your QRS? But also for things like pre-excitation, in where the PR interval is really, really small. And actually there is a P before every QRS, but it's really, really tiny. There's other fancy things like the P mitrale and a P pulmonale if you do a lot of reading, but it's not really used that often on a day-to-day basis. So we'll just keep it simple with, is there a P wave and is there a P before every QRS? And then what is the relationship between the P and the QRS, essentially? So I thought I had a rhythm strip there, but I didn't. Oh, no, it's here. So I've got a few different strips now to just look at, you know, common things that would come up kind of when you're looking at the P waves. So this is a sinus rhythm. So there's a P before every QRS. So the atrial contracting synchronously, and then so is the ventricle. This is an example of atrial flutter, and with a 3-to-1 block, which essentially means you've got 3 episodes of flutter, 3 episodes of atrial contraction before every QRS. So this is why the relationship's important. You know, how many P waves are we having before the QRS? But then, is there a P before every QRS? And there is. And again, I'm not going to go into flutter in loads of detail. We'll cover this in other sessions. It's just to think about the basic ECG interpretation. And then in this rhythm strip, I can't see any P waves at all. So this, by definition, is atrial fibrillation because there's no P wave contraction. So that's just a bit of an example of those 3.
So Steph, I just wanted to just to say, can you hear me at the moment?
Yes.
Yeah. Perfect.
Sorry, I went and I came back.
No, that's fine. So really, you know, going back to when you're talking about rhythm assessment, and you mentioned about, you know, regular or irregular, that's you know, it's really important to look at that. But we've seen examples here where you've got the, you know, the top 2 ECGs, both have got regular rhythm, you know, they're both regular rhythms. But the fact that it's regular doesn't necessarily tell you that it's automatically, you know, normal sinus rhythm. So that's something to bear in mind, that you have to, like Steph said, you have to look at the P wave and look at the morphology of the P waves to work out what the rhythm is. And then the other thing we've seen as well is that at the bottom, it's irregularly irregular, and it's you know, this is an irregular rhythm, but we also, which is atrial fibrillation. But the previous slide, if you go back, Steph, if you go back, yeah, go back, back again, back again, back again, keep going back, yeah. There.
Eh?
Okay, yeah. So this is an example of, at the top you've got the regular rhythm, sinus rhythm, but at the bottom you've got an irregular. It's irregular. You can see that very, very clearly if you look at the R interval. The 2 ones that have been highlighted there, you know, there's one shorter and then there's one longer. So that's irregular, but it's still sinus rhythm. So it's the P wave morphology and the P waves that tell you what the rhythm is. So that's all I wanted to pick up on. So yeah, if you can carry on.
Yeah, just give me a second just to get back. Okay, so we've talked about the P waves. And then what is the PR interval is the next kind of part of your assessment. So it's just important to think, what does the PR interval represent? So I don't know if anyone has any thoughts on this. What is happening in the PR interval, and why is it then important, I suppose?
Everybody's thinking very hard about this question.
Yeah.
There's no activity on the. Oh, somebody's mentioned the ventricles filling. Somebody else has mentioned, is it the time for depolarization to spread from the atria to the ventricles? And someone has mentioned, is it the time to conduct through the AV node? And someone's mentioned AV node is holding.
Yeah, so essentially it's the time. You know, all of these things are right. So, you know, there's a delay between the atrial contraction and the ventricle contraction, so that you have ventricle filling before then contraction. But from an ECG and from an electrics point of view, it's the delay through the AVN that allows that to happen. And that's what the PR interval is. It's that delay and that time, which obviously is important. So I don't know if anyone knows what the PR interval should be, but this is obviously important to know kind of when you're looking at the PR interval. So I have put it here somewhere. Oh no, this is me calculating the PR interval. So it's 3 to 5 small squares, and I put it in seconds, but you know, essentially you're looking about whether it's at least 3 small squares up to 1 big square or 5 small squares. And you can assess this by, you know, drawing 2 lines at the start of the P wave and the start of the QRS complex, and measuring, you know, that time difference. And like what we were talking, I talked about briefly before, this is important for, you know, assessing whether you've got any pre-excitation, so whether there's not enough time for the ventricles to fill, because the AVN isn't slowing the contraction down, you've got an accessory pathway that's just excelling things, or because of an AVN block. So these are just a few examples of blocks, because I feel like these come up quite regularly. So I have put them in order. So it's you know, like what I said here, you know, it's 3 to 5 small squares, and I think you can quite obviously see that this PR interval is much larger than that. So this is a 1st degree heart block. Next, you've got an example of varying lengths of PR interval. So you can see kind of from in the 1st beat, it looks relatively normal, and then it's prolonged and it gets more prolonged, and then you have a P wave with no conduction, which again, going back to the other thing, is why the relationship between the P and the QRS is important. So by no conduction, essentially what I mean is there's a P wave but no QRS immediately after it, and then there's another P wave before there's another QRS. So this is a 2nd degree heart block, Mobitz type 1, or when the going, gone, you know, in your textbooks. Essentially it means that the PR interval is prolonging until you have a P with no QRS after it. And then this rhythm strip, you can see, again, there's a P before every QRS, there's a P before every QRS, and then there's a P with no conduction. But you know, this is different to the one above it because there's no prolonging PR interval. And then finally, these P waves are just not related at all to the QRS complex. They're just doing their own things. H is doing a completely different thing to the ventricles, and this would be a complete heart block. I don't know if Ahmed's got anything else to add on that.
No, that's great. And if you're interested in heart block, we do have a talk available on heart block where we go into a bit more detail about it.
Yeah. So then, you know, we just briefly talked about before, you know, with pre-excitation and shortened PR interval. So, you know, it's important to also look for a small PR interval as well as a prolonged PR interval. As you can see here, this is a small P wave, not really any PR interval, and then this is what you call a delta wave. So you can see there's an upsloping QRS complex, because there's been an accessory pathway. So yeah, so we've talked about the P wave mainly. So if we go back to our initial ECG, I don't know if anyone wants to say anything about the P waves here. If there is any P waves, if we go back to the checklist, it's, you know, is there any P waves? What is the relationship with the P waves with the QRS? And then what is the PR interval? So I don't know if anyone has anything to say about that.
Okay, so again, people are a little bit shy to answer this, so nothing so far in the chat.
Okay.
Oh, actually, yeah, somebody's mentioned that there's prolonged PR interval, but there's a fixed PR.
Yeah. So I don't know if anyone has any thoughts on where it's best to kind of look at a P wave. Yeah, Bobby's done well. He's gone ahead slightly. So in lead 2 and V1 tend to be the best leads to look to see P waves. So if you look in lead 2, you can see that there is a P before the QRS. But like what Ryan said, there is a prolonged PR interval, and fixed. What he means is that it's prolonged before every QRS complex. It's always prolonged. It doesn't change. So this would be a first degree heart block, in that way. So I've just kind of circled these so that everyone can see them, that there is definitely P waves there. And then this, I've zoomed in on this so you can see a bit closer, but essentially you can see here that it's way over one big square. Sorry, those lines are a bit thick actually. I think they probably take up a square themselves, but yeah, you can see that it's prolonged. Okay, so moving on. So now I'll move on to the QRS complex. So first we start with the Q waves. So we're just briefly talking about Q waves here because it's in the context of ischemia, is something that sometimes we look for in an ECG. So essentially you can see here that there's a very, very deep Q. So the Q wave is the first kind of negative deflection after you've had your P wave. So you can see here in lead 3, there's a very deep Q wave. And this would be something that we would call a pathological Q wave because it's very, very large. And Q waves do tend to be territorial. So if someone's had an inferior MI, which we'll talk about the leads that you look for that later on, the Q waves would correlate with the leads where they had their ST elevation, ST depression. They would be in the same kind of leads. You can see it's a very deep Q wave there. So I have just wrote down the kind of criteria for pathological. Oh, there you are. I was thinking I should have had a. So yeah, you can see here the Q wave's the first part of the QRS complex. So the R is the positive deflection. The Q is the first negative deflection. So here's the criteria for the pathological Q wave. So it's definitely, if I go back, it's definitely over 25% that deep Q wave of the the RS complex. There is some other things there just to kind of look out for. And then I've just put also what does the kind of QRS look like as a whole, really. And this is important mostly for looking whether there's a broad QRS or there's a narrow QRS. So what is the QRS duration? So I don't know if anyone knows what a normal QRS should be in measurements. Yeah, 120. So it's 3 small squares. So it's easy to remember because the PR is 3 to 5 and the QRS is 3 or less. So it's the same numbers, so you're not having to remember something extra. 3 small squares is correct. The normal is less than 3 small squares. So again here, just so that we can have a look at it, you can see this QRS is about 1 small square, so it's a normal narrow QRS. So mainly we're seeing if it's broad. So if it's more than 3 small squares, it would be a broad complex. And I'll show you some more examples of that shortly. So these are some examples of differing QRSs, and again, they're quite important things to kind of look out for, hence why we've got a slide on them. So I don't know if anyone knows spot diagnosis what this is, because this is one of those things. Yeah, it's VF, so something you just kind of get used to looking at. So, but if you narrow it down and look at it from your ECG step-by-step thing, you can see all these QRSs are all broad and it's irregular, which by definition means it's BF until proven otherwise, essentially. So this one, does anyone know what this is? Yeah, so this is a VT rhythm strip. Again, it's a broad complex. We're over those 3 small squares, but it's regular this time. So this would then be classed as VT. And then this one, an SVT. So essentially, this one's a narrow complex, regular rhythm. You could just start by just explaining, exactly what you see. So you've got an irregular broad complex tachycardia for the first one. You've got a regular broad complex tachycardia for the second, and then the third, you've got a regular narrow complex tachycardia. So I don't know if anyone's got any questions on this. I don't know how.
So what I would say, Steph, is is that the top one, VF, it's one of these ones you just have to recognize it, and it does come up in exams, and sometimes in OSCEs as well. You just have to recognize it, and you just But the second and the third one, a lot of people will go and say this is VT and this is SVT, but actually it's better to say that it's a regular broad complex tachycardia or a regular narrow complex tachycardia, because when you use the word VT or SVT, you're giving it a diagnosis, and you should keep things simple because there are differential diagnoses for broad complex tachycardia, and it's not always VT. So that's just something to bear in mind.
Okie dokie. Right. And the next thing we'll go on to is bundle branch block, because that's kind of part of you kind of looking at your QRS complexes. So I've just included a brief picture of, just thinking about where the heart sits in when you're actually looking at the leads, which is something that we don't always do, I feel, because you just look at the ECG in isolation. But actually, if you think about where the V1 to V6 are, it's actually quite useful, especially for this, understanding this. But essentially, again, you can find these in textbooks. You've got right bundle branch block. You look at V1. You're looking at V1 and V6. So in V1, you have this classical M picture, and then in V6, it's supposed to look like a W, but essentially it's a broad QRS complex. And then bundle, the left side, again, it's supposed to be the other way around, isn't it? So there's a W in V1-ish, and then there's an M in V6. And essentially this is, the reason why I've included the V1 to V6 is if you imagine if there's a block on the right side, your heart's going to depolarize on the left side first and then go across to the right. So, V6 will remain positive, but in V1, because you're looking at the right side of the heart, that's why there's a negative, a deeper S wave before it then depolarizes across. Sorry, there's a fly. And then if on the other side, if there's a left bundle branch block, your heart's going to depolarize on the right side first, and then go across to the left. So that's why, it's a negative deflection, because it's depolarizing away from V1 and towards V6. I don't know if that makes sense. That I found when someone explained that to me, that made it much more sense to me. So that's why I thought I'd just try and explain it. I don't know if that made sense, but essentially, again, it's similar with other ECG things. A lot of it is just pattern recognition over time. So I don't know if anyone can tell me what this side is. What block this is. Yep, so this is a left bundle branch block.
Somebody's mentioned left bundle branch block, yeah.
So if I go back, just so that we go between. So, you can see the V1 there and the V1 here, it's broad. And then based on that, what is this one? This one will be right. And as you can see, this is more got the classic kind of M, V1, V2, V3. And then in V6, it's broader with a kind of up sloping from the S wave. So then if we go back, then we'll talk about the QT interval. So we've talked about the Q waves, your QRS complex, and now we're talking about the QT part of the complexes. So
Steph, just to say you're over half an hour.
Okay, I think we'll be okay. So this is how calculating the QT interval. So it's from the very, very start of your QRS complex all the way to after the T wave. And I don't know if anyone knows what the QT interval should be and how we calculate the QT interval.
I think it's best if you explain this one because it can be quite difficult to explain.
Yeah, so essentially the QT interval changes with the rate that your heart's contracting. So the QT interval is the time from the whole ventricle's doing everything. So from the ventricles contracting and to then relaxing again, because that's what the T wave essentially is. So it's that whole kind of process. And so it varies with rate, because obviously if we go faster, you've got less time to do that. So essentially we calculate the QTC based on the rate. So in practice, there's lots of things on MedCalc where you can just put in what formula you want to use, heart rate is, then you can calculate the QT interval, and then it will tell you what the QTC is. And essentially there's different, different levels for females and males. But then if you've got a prolonged QT, there's lots of pathologies that would include. So essentially looking at the QT interval in seconds, and you're dividing it by the RR interval. But in practice, you can MedCalc calculation, which is probably more accurate than you figuring it out yourself, really. Okay, so if we go back to our ECG, so we now covered the QRS complex and the QT interval and any bundle branch block. So I don't know if anyone has anything else they want to add about ECG that we talked about at the beginning. So I think I have circled some of these. I don't think anyone. No, so it's quite hard, this one, but essentially at this point there is actually a right bundle branch block. So if you can just see, there's like you can see the M in V2 more than V1 here. There is a very, very small start of the M at the very beginning of that V1, but it's much clearer in V2. There is the M there. And then if you look at V6, it's kind of broad, and there's this up sloping after you've had your R wave. There's that S wave that's kind of up sloping. So that's broad again, a broad QRS. So essentially, this is right bundle branch block. So now to go on to the ST segment. So we've talked about the QRS, but now looking at the ST. So essentially, we're looking at, is there any ST elevation? What type of ST elevation is this? So what does it look like? Is there any ST depression? And if so, where is the ST elevation depression? So this is what we mainly use if we're looking for an acute MI. So the different ST elevation, so they can look different depending on what the thing is. But mainly we're looking, is it an MI ST elevation or is it a pericarditis ST elevation? So I've got pictures of both of these that I've just taken from Life in the Fast Lane. So essentially, ST elevation in an MI setting can look like any of these, basically. So tombstoning, really high, very obvious ST elevation. Whereas in pericarditis, you get this kind of like concave picture where it kind of upslopes. It looks like someone's just signed a signature at the end. I always think, they've just gone a little like flick. Whereas the ST elevation from the MI is much sharper. So that's essentially the differences between those two. And I think when you see a pericarditis ST elevation, it is quite obvious. So if you see any of them on placement, have a look and just to help solidify your memory. Then the next thing is territories. So I don't know if anyone knows the territories on an ECG, but essentially, I always do the right coronary first or inferior leads, because they're, in my head, they're the inferior of the ECG. Well, even though they're inferior on the left, so they're kind of the bottom of the ECG. And then lateral, I always think that's the sides of your ECG, because lateral is the sides. So that would be 1 AVL, V5, and V6, and that's your left circumflex territory. And then anterior, or your LAD, is in the middle, because that's the middle of your heart, and the most important, really. So that's the anterior or LAD territories. So if you had ST elevation in 2, 3, and AVS, that would be inferior MI, inferior ST elevation, and it's probably going to be a problem with your right coronary artery when they go in angiogram. That's quite an important slide to note. And again, when you look at ECGs on the ward, you can, just have a think through these things. Then finally, what about the T waves? So any T wave inversion or flattening, any peaked T waves, and if so, what territories again are they in? So this would be something more that we would look for if we thought someone's having an end STEMI. There's no ST elevation, but there is an ischemic change in their ECG if they've got T wave inversion in a territory. And so here's just some examples of T wave changes. So you can see in the left picture, there is in the 2 and 3 and AVS, there's T wave inversion. So like what I said before, this is T wave inversion in the inferior lead. So this is suggestive of inferior ischemia. And then on the right, this is an example of kind of peaked T waves that you might see in hyperkalemia. So really tall T waves, although I think there is a ST elevation in that one as well, but these are very high T waves. So again, just looking at the T waves to see if there's anything going on, basically.
So the other interesting thing about the T waves, if you go back to that previous slide, is that peaked T waves are often the first sign of an acute MI. So even before they develop a sort of classic ST elevation, you get this feature of peak T waves. So if the patient's got chest pain and that type of ECG, think about, are they having a STEMI?
Yeah. Okay, so then if we go back to our ECG and we just think about the T waves and the ST, and the ST changes, I didn't really see a lot on this one. Oh, I didn't even label it. So essentially in lead 1, there is a bit of an AVL. There is some T wave inversion, but I'm possibly in V1, V2, and V4. But again, yeah, just the next kind of part of the QRS complex. So I think Stephen's already mentioned. So overall, what we've kind of, said from this ECG is it's a regular rhythm. The rate was about 772, wasn't it? If we go back through, there is left axis deviation, there is a right bundle branch block, and there is a first degree heart block. So left axis deviation, first degree heart block, and right bundle branch block often are classified as the trifascicular block. which just essentially means that there's a right bundle branch block, but there's left axis deviation because there's possibly a left anterior vesicular block, so part, as well. So, if this patient came in with syncope, we'd potentially be more concerned about this ECG. But otherwise, that would be the general kind of assessment from it. Yeah, so that's kind of like my brief run through of basic ECG teaching. I don't know if anyone has any questions or anything Ahmed wants to ask before I just have my summary point.
Yes, so I was just saying, in terms of the T-wave inversion, so ischemia is a major cause of it, absolutely. But there are other causes as well, and you should bear in mind that some cardiomyopathies can be just, the main diagnosis can be based on T-wave inversion on the ECG. So just be aware that there are other causes of T-wave inversion.
Yeah, and there is other causes of FT elevation. I've not gone into them in too much detail, just because I wanted to kind of just cover the real basics really with this session. Because I mean, as you can probably tell, the ECGs is a big topic. But like what I said at the beginning, it's all about what's the clinical context. And if you're early on in your stage, and it's just about getting used to going through the kind of rate rhythm, and having a systematic approach to it, and having a look at as many as you possibly can, and asking if you don't understand, and you want some help with them, because I'm sure throughout mine and Ahmed's career, you look at hundreds and thousands by the time. So sometimes people can make it seem quite easy, but everyone was at that stage at one point where you look at it and you just think it's just wiggly lines. So
yeah, the other thing to say about the T-wave inversion as well is that in this ECG, you've got T-wave inversion in V1 to V3, and that's actually part of the right bundle branch. So yeah, you can get the right bundle branch. You often get T-wave inversion. That's just part of that, really. So. I don't think we've got any questions at the moment, Steph, so you could go to your summary slide.
Yeah, so summary is just take your time with them, go through the systematic approach, always think about the clinical scenario, and I've said that a few times, but it is important. This is just a basic start, just to give you a brief overview. We'll go through ECGs, in multiple other topics that will kind of relate to what we're talking about. And like Ahmed said, there is other talks on the website. If you want to have a look at something that's more specific, i.e. heart block or whatever. Just don't be scared about picking them up, looking at them. Especially with the bundle branch blocks and left axis deviation, things that the more you look at, the more you'll get. So I just wanted to just put that back up, the kind of checklist, just so that everyone can see, and then I will just post in the chat the link to the website. And there's also a talk on diabetes that Ahmed's running, and I will post details of that as well. Don't have all of it. I don't know if that's actually worked. Anyway, I'll send that out through email to everybody as well, Ahmed. I think that might be easier because it's a bit difficult on this form. And thanks everyone for joining us, and hopefully those people that are new, hopefully you'll be able to come back and for further talks, because we've got quite a lot planned. So then our next one with the CMST group will be in 2 weeks' time on aortic dissection. And it's really important if you can fill out the feedback form, because we're still kind of adapting and making things better for you all. So any feedback you give us will be very useful for that. Yeah, so hopefully that all made sense.
Before we go, Steph, thanks for the talk.
Yeah.
Really, really good. There's just a quick question from someone in the chat about why is it important if we know the axis? And so if it's a left, normal or right, just to pick up on that.
Yeah, I'll just go back to so, right axis and left axis deviation, depending on the clinical scenario is important. So if you think someone's got right-sided heart failure and they've got a right axis deviation, things like that, again with MI, cardiomyopathies, if you've got left axis deviation, and what I've mentioned is part of trifascicular block, axis is important as part of knowing whether they've got trifascicular block, because it's one of the criteria for that as well. Life in the fast lane has lots of reasons for left and right axis deviation, but I suppose they would be the main thing. So if somebody came in with a chest pain and they had right axis deviation, you might be more thinking that this could be a massive PE than this could be a acute MI. But if they came in with the same presentation but had a left axis deviation, you might be more suspecting that they've got an acute MI with some left-sided heart strain. So I suppose in that scenario axis is important to kind of
cardiac pathology. So it's important to recognize axis deviation. As Steph said, both in acute setting, things like acute PE, you get right axis deviation, but also it can be a feature of pulmonary hypertension, right axis deviation, and also left axis deviation could be a feature in cardiomyopathies as well, and heart failure. So the ECG is like a window to the heart, and it's a very cheap, very simple test. It takes 5 minutes to do, costs I think 2p to do, but you can.
Yeah, so you can see a lot, can't you, from?
Yeah. Now there were a couple of questions, and I don't know if you've got a couple of minutes just to go through them. So the first point was someone was asking about broad complex tachycardia and narrow complex tachycardias, and is it VT, is it SVT? So we want to keep this very simple. If you've got a broad complex tachycardia that's regular, 9 times out of 10 it's a VT, it's ventricular tachycardia. But there are some occasions where it's not the case. You just have to be aware of that. But there are possibilities where it's not the case. Similarly, with a narrow complex tachycardia, it could be due to SVTs, but you can also get narrow complex tachycardias. You can get some VTs, can be quite narrow as well. So from a simplistic point of view, the best thing to do is just to describe it as being broad complex tachycardia or a narrow complex tachycardia. We don't have time to go into the details, unfortunately, but if you are interested in these things, we've got recording. See is that the QTC is the time from the start of ventricular depolarization to the end of repolarization. And the reason it's important is because a long QTC
Ahmed, I think you're going in and out. I don't know if it's just my connection or everyone is having the same issue. Yeah, I think there's just a bit of difficulty with the hearing.
sorry about that, guys. I think I lost connection. Sorry, going to carry on. Sorry.
I think we lost you, Ahmed, mid sentence. So I've
yeah. What did I get?
I think you were saying about QTC. I think was probably the last thing you said.
Okay, so the point I wanted to make about QTC is so the QT interval is the time from the start of ventricular depolarization to the end of repolarization, and the reason it's important is because a long QT can be associated with an increased risk of ventricular arrhythmias, things like torsades, and even sudden death. And it's important to recognize that on the ECG, particularly because some of the commonest causes of long QT are medications and ischemia, and you don't want to be giving patients medications that can make the QTC even more prolonged. So that's, and it's one of these things that you have to look for, because you will forget about it. You'll miss it if you don't actively look for it. And the other thing, the other question, I think was, I think we've covered the other question about the
axis, yeah. And oh, my internet's unstable as well. The other one said, does a normal heart have a normal axis? I suppose for that point is, you know, the ECG, there's lots of things other than axis. So just because the axis is normal, something else could be happening. And you know, what we've said is you take in the axis with part of whatever somebody's come in with. So axis is suggestive of kind of heart failure, cardiomyopathy, kind of right heart strain because of something, you know, with your lungs or pulmonary hypertension. So I would never say that, you know, just a normal heart has a normal axis, because there could be something else going on that's just not causing an axis deviation. So if no one has any more questions, we'll leave it there. Yeah, we'll see you again in a few weeks, and please fill the feedback form in. I have put a link in the chat to the website where you can find more stuff if you need it. Yeah. So Zach, are you okay to stop recording, and we'll leave it there?
Yeah, sure.